Thank you very much. Elizabeth Ruebush has a comparable job, Director of STD, HIV, and Viral Hepatitis, but this is for the Association of State and Territorial Health Officials, so a different level of government. Thank you.
Great. Well, thank you so much to the National Academies and the committee for having me here today. We really do appreciate the opportunity to share the state-level perspective on STI prevention and control. Let's see. I might be doing this wrong. There we go. All right, so today I'll be sharing some data from internal ASTO scans and 2 surveys that we've fielded externally. The first is the ASTO Profile of State and Territorial Health, which was funded with support from the Robert Wood Johnson Foundation and the Centers for Disease Control and Prevention. And the second is the Public Health Workforce Interest and Needs Survey, and that was funded with support from the de Beaumont Foundation and fielded in cooperation with ASTO, NACHO, and the Big Cities Health Coalition. For those of you who may not be familiar with ASTO, we're the Association of State and Territorial Health Officials, and we represent the chief health commissioners in the states, territories, and District of Columbia, in addition to the over 100,000 public health professionals that work in those agencies. We're lucky in that we don't do this work alone. We have great support from CDC and our partners at NACHO and NCSD, who help us advance governmental public health priorities and really bring our efforts up to scale. So today I'll be sharing a bit about state public health agencies, who we are, what we do, and how we do it, specifically as those elements relate to STI prevention and control. I'll discuss the core infrastructure, workforce, and partnerships that help us get this work done, in addition to some of the high-level challenges and opportunities that are on the radar for our state health commissioners. So to understand state-level STI prevention and control, I think it's helpful to take a step back and understand a little bit about state health agencies themselves. State health agency structure varies across the United States. A majority of these agencies are freestanding agencies, and that's represented in red on this chart, whereas others are part of a larger organization, often referred to as an umbrella agency or a super agency. And in many cases, the other programs that are housed within the umbrella agency with the state health department are Medicaid, the State Mental Health Authority, substance abuse, and public assistance. Just as agency structure varies, so do the roles and responsibilities of ASTO's members. A recent scan found that in addition to overseeing the state public health programs, 5 state health officials have statutory oversight over Medicaid, 8 have oversight over substance abuse, and you see a few more examples on the slide. And I mention this information and the information from the previous slide because I do think that the oversight authority that our health commissioners have, in addition to the relationships between sister agencies at the state level, do have implications for the opportunities and partnerships that state health commissioners can leverage to affect change. In terms of governance, I think a lot of this information was nicely teed up by Gretchen. Nearly 30% of our states are centralized and half of the states have a decentralized system. And this really speaks to the dynamic of the relationships between the state health agency and the local health departments. And these governance differences have an impact on how public health services are delivered. State health agencies oversee large and diverse portfolios, but infectious diseases and specifically STIs are on the radar as a priority area. ASTO conducted a scan of state health improvement plans, which highlights state priorities and objectives, and we found that 43% of those plans did call out STIs as a priority. However, we also know that our state health commissioners are encountering significant challenges in advancing these STI priorities. Funding for STI programs and services haven't kept pace with increasing population size and burden of disease, and I think we've heard that from a few of our speakers. And our public health leaders have raised concern about a perceived lack of urgency and focus on STIs amongst the public, some healthcare providers, and in some cases, other public health professionals. Beyond that, ASTO's experience shows that state health commissioners are confronting increasingly complex public health challenges and an array of competing priorities. We have the opioid crisis, chronic diseases, public health emergencies, and the list really does go on. Encouragingly, infectious diseases and STIs are on this list of priorities, and as much as possible, we need to clarify the link between STIs and these other high-profile public health priorities. And when appropriate, we need to support health officials in acting on these priorities and supporting an integrated response. As you might expect, the structure and scale of state-level STI programs vary across the board, but they do have some core programmatic services that are consistent, ranging from surveillance to testing and linkage to care. And health agencies provide essential STI prevention and treatment services. In many cases, the state health agency is one of the leading entities doing this work. On this slide, we have data from 2010 in dark blue, 2012 in the light blue, and 2016 in red, showing the percentage of state health agencies that have reported providing STI screenings, treatment, and STI counseling and partner notification. Over the years, you can see that the proportion of state health agencies that are providing these services appear relatively stable. However, what these data don't fully reflect are the level at which these services are being provided. So in other words, while we know that the percentage of state health agencies are providing, we know the percentage of agencies that are providing these services, and we know that that percentage might stay relatively stable over the years, behind these numbers, we know that health agencies have experienced STI clinic closures, decreased staff, reduced hours for providing these services, and all of these factors negatively impact public health agencies' ability to adequately deliver STI treatment and prevention services to those populations that need it the most. Now, moving to some of the core components that allow our health agencies to do the work that they do. Public health infrastructure is critical to help states prevent and respond to STIs. Making the case for this infrastructure is challenging, and to support that effort, ASTO and NCSD, the National Coalition of STD Directors, have developed a customizable fact sheet to help health agencies communicate the impact of STI infrastructure investments on disease burden, health outcomes, medical spending, and other factors. The fact sheet uses outputs from CDC's Space Monkey tool, and together these two resources are really valuable in quantifying and communicating the impact of program investments on STI outcomes. Program investments also allow us to support a capable and qualified state public health workforce. In STI programs, I'd specifically like to call out the role of disease intervention specialists, or DIS. They are critical frontline workers for our health agencies, and their impact extends far beyond the STI program, as they've been used to conduct contact tracing for Zika, Ebola, hepatitis, HIV, and other infectious disease outbreaks. Unfortunately, we also know that 1 in 3 state health agency workers have reported that they're considering leaving their agency in the next year. This is concerning, and we anticipate that the effects of these departures will be felt across the state health agency. And for STI programs in particular, these departures result in a loss of critical expertise and staff capacity to respond to an epidemic that's really not showing any signs of slowing down. And our health commissioners will need to prioritize succession planning, recruitment, training, and mentorship of staff in order to address these workforce challenges. State health commissioners are in an optimal position to broker relationships with partners, both internally and externally. And when we look within health agencies, some of these key partnerships to build or expand upon are in HIV programs, maternal and child health and injury prevention programs to address congenital syphilis and the intersection of STIs and drug use. And when we think about cross-sector collaboration, we're looking at engaging providers and pharmacists to support EPT implementation, Medicaid and private payers to ensure coverage of 3-site testing, and collaborations with harm reduction programs to integrate screening and treatment services. This is by no means an exhaustive list, but I think it serves to call out some of the areas where our health commissioners might have influence and the ability to broker important relationships. In terms of the outlook for state-level STI prevention and control, our health officials are responding to current challenges, such as the alarming increases in congenital syphilis, and monitoring emerging threats, such as antibiotic-resistant gonorrhea. Our health commissioners are also well positioned to leverage HIV elimination efforts, and there's a strong case for doing so from a biological and epidemiological standpoint, and in terms of infrastructure, where existing services and programs can be leveraged to benefit both disease areas. And I think we heard earlier this morning about how it's important for this to be a two-way street, with STI clinics potentially serving as a really important location for HIV testing, counseling, linkage to PrEP and HIV treatment. And on the other hand, we have Ryan White funded facilities, for example, that really can do a great job of integrating STI testing and prevention services into their programs. Finally, ASTO is very encouraged by some of the signals of national coordination around STI prevention and control, and I think the fact that we're all here today really does speak to that. The move towards the STI Federal Action Plan is a promising development, and we look forward to future iterations of that work that specifically call out strategies for states and territories. And we recognize the need for national coordination or a campaign to raise awareness and reduce stigma around the STI epidemics. I think we've heard from many speakers today the importance of communications. ASTO is doing what we can to communicate with our constituencies and the media, and I think a coordinated effort around this could really be really valuable for our members. We are willing and ready to support the recommendations of this committee, and I very much appreciate the opportunity. Thank you all.